Good morning, students. So today's topic for our lecture is pulmonary embolism. Introduction. Venous thromboembolism and pulmonary embolism is the third most common cause of cardiovascular death after myocardial infarction and cerebrovascular accidents. Many pulmonary embolisms are likely undiagnosed and calculating the true incidence remains challenging. Their risk factors are most clinically significant pulmonary embolisms originate as venous thromboembolism in the lower extremities or pelvic veins. Less frequently, upper extremity thromboembolic event leads to PE. Various conditions lead to the generation of VTE, that is venous thromboembolism. Virtuous triad of hypercoagulability, venous stasis, and vessel wall injury provides a model for understanding many of the risk factors. This is table number 1, where you can see inherited risk factors for VTE with hyperhomocysteemia, medium mutation in the factor V-leadin, and in the strong, we will see deficiencies of coagulation and inhibitors, including antithrombin, protein C, and its cofactor protein S. Yet in the medium, you can have a look at mutation in the three untranslated part of the prothrombin factors, gene prothrombin, pathway inhibitors, thrombomodulin, and endothelial protein C receptors. I've been seeing a strong one. Here you can have a look at table number 2, which is having required risk factors of VTE. Let's move forward on the next slide. Virchow's triad. Rudolf Virchow described 3 factors that are critically important in the development of venous thrombosis. That is venous stasis, activation of blood coagulation, and a vein damage. These 3 factors have come to be known as Virchow's triad. Add thrombosis risk. Pathophysiology. Pulmonary embolism occurs when deep venous thrombi detach and embolize to the pulmonary circulation. Pulmonary vascular occlusion occurs and impairs gas exchange and circulation. In the lungs, the lower lobes are more frequently affected than the upper, with bilateral lung involvement being common. Larger emboli wedge in the main pulmonary artery, while smaller emboli occlude the peripheral arteries. Peripheral pulmonary embolism can lead to pulmonary infarction manifested by intra-alveolar hemorrhage. Pulmonary infarction occurs in about 10% of patients without underlying cardiopulmonary disease. This contributes to ventilation perfusion mismatch with vascular occlusion of the arteries, increasing pulmonary vascular resistance. Rapid progression to myocardial ischemia may occur with potential for hypotension syncope, electromechanical dissociation, or the sudden death too. Clinical presentation. Unfortunately, pulmonary embolism may be asymptomatic or present with sudden death. Characteristic signs and symptoms such as tachycardia, dyspnea, chest pain, hypoxemia, and shock are not specified and are present in many other conditions such as acute MI, congestive heart failure, and pneumonia. Common signs were tachypnea, that is up to 54%, and tachycardia, that is up to 24%. The most common symptoms were dyspnea, usually of onset within seconds, at rest, or with exertion. Pleuritic pain, calf or thigh pain, calf or thigh swelling, and cough. Evaluation. Because of the variable nature of the presentation of pulmonary embolism, the evaluation largely depends on the likelihood of pulmonary embolism and the stability of the patient. Diagnostic scoring systems such as the Wells criteria and Geneva score are often used. Here you can have the look at the table. These are revised Geneva scores. And this is pulmonary embolism rollout criteria. The aforementioned tools, well scores, Geneva score, and PERC work best in assessing the needs for further workup of stable patients presenting to the emergency room. With inpatients and critically ill patients, such tools are not as reliable. Extremities venous ultrasound is a quick, non-invasive modality that can detect DVT because it can be performed with a portable machines. Venous US may negate the need for potentially dangerous transport of unstable, critically ill patients. Helical CT angiography has largely replaced ventilation, perfusion, lung scanning for diagnosis because it is rapid, permits direct visualization of PE, and can demonstrate other diagnosis in patients without PE. In patients with a contraindications to intravenous contract, die, a VQ, that is ventilation perfusion scan, is used. EKG or echocardiography may support the diagnosis as well as provide information about the severity of the PE. One particular finding on echocardiogram, known as the McConnell sign, is it is strongly suggestive of PE. Here comes the differential diagnosis. Pulmonary embolism may be confused with other conditions impacting the cardiopulmonary system. These conditions include acute heart failure, pneumonia, chronic obstructive pulmonary disease, atrial fibrillation, and acute myocardial infarction. Its treatment include in hemodynamically stable patients without contraindications to systemic anticoagulation, parenteral anticoagulation with subsequent conversion of vitamin K antagonist is the mainstay of therapy. Patients who present to the emergency room with acute PE have decreased mortality if anticoagulation treatment commences in the emergency room rather than waiting until after admission. Supportive care of hypoxemia and hemodynamic Instability should be instituted. Hemodynamically unstable patients may benefit from fibrinolytic therapy. The use of bolus thrombolytics during cardiopulmonary arrest may have some benefit when pulmonary embolism is strongly suspected. Systemic heparin, either in the form of unfractionated heparin or low molecular weight heparin, is the mainstay of the treatment. Newer options for anticoagulation include oral factor XA inhibition such as rivaroxaban. If patients continue to have pulmonary embolisms despite therapeutic anticoagulation, permanent or temporary inferior vena cava filters may be used. Thank